to grow. So what I'd like to do is explain a little bit about where I work and what I do now, because oh, I hit it, got it, and it moved me. There we go. So we work with treatment-resistant patients. I work with a psychiatrist, a psychiatric nurse practitioner, and myself. And we're located in Auburn, California, which means my office is 70 miles from my home. The reason I have been doing this off and on for almost a couple of decades is because I found that neurofeedback is a very powerful treatment. And yet most of the individuals I worked with were on medication, and I couldn't get a lot of cooperation from people who were prescribing when I'd say, hey, their brain is starting to get more efficient. You know, you have to consider reevaluating their medication. Well, you know, they didn't want to do that. And I was introduced to Dr. David Foster, and he had an individual in his office doing neurofeedback who trained under the same group that I had trained with. And now they gave him my name. I consulted with people almost from the start of this in helping them learn how to do neurofeedback effectively. And in 2003, I started teaching for EEG Spectrum. It's now called Eager. It's a software company that made the software. You're going to see some of it tonight. And so every month I taught a 4-day course all around the United States, as far away as Johannesburg, South Africa, for almost 10 years, while maintaining a practice the other 3 weeks. You see, I'm only 47. No, I'm just kidding. But it was definitely a pace, and I enjoyed every minute of it. I learned more from the people that wanted to take neurofeedback than I could probably ever teach them as one person. It was a fantastic experience, and it really helped my skills, and it continued to foster my desire to spread the word about neurofeedback. It's a wonderful treatment, and I hope at the end of this here, you'll have a little bit of a better understanding. Now, since I taught it for many years, if I get into teaching mode too much, just let me know. It's just something that may happen. I'm going to try not to do that. So I work with David Foster. He's a psychiatrist. He's very well known in Northern California. He has sat in on over a dozen death row inmate evaluations, most of them serial murderers. Some of you may remember 35 years ago, Bill Bonin, the LA freeway murderer. He spent many days in a cage, a plastic cage in a prison, interviewing him.
Trying so hard to make friends, so hard, right? But I had to step back and be like, what am I?
And so his intention of doing that work, not only to, you know, evaluate these individuals, but to get a sense of where this all started with them. And the reason being, he's also a child certified in board certified in child psychiatry, is that he was working with a lot of foster children and, you know, a lot of group home children. And what he saw was scaringly similar types of behaviors that were reported being in the youth of some of these murderers. And he thought, wow, if we could change the pathway of these individuals as children while they're still malleable, you know, we might be able to stop some of them from growing into Bill Bonins, and also the Unabomber, Kaczynski, he evaluated him. Interestingly enough, they didn't really share his opinion back then, 30 years ago. He said that he was Asperger's with psychotic traits. They diagnosed him at the time as schizophrenic. Just recently, there was a show on TV about Ted Kaczynski, and one of the psychiatrists interviewed said, gee, you know, we're coming to realize now that he may have been on the autistic spectrum. So Foster is a very unique individual. I cherish working with him. He's different in many ways, prescribes a lot of supplements, does complete board panels with everyone, very much along the lines of what Clearfield does, only for different purposes, right? He's looking at psychotropics. So we get along. When I say we get along, once again, when I first started, it was hard to get someone to realize that maybe the medication doses may have to be changed as the brain becomes more efficient. We'll talk about that a little bit. And also Colleen Phelan is a psychiatric nurse practitioner. Her specialty is working in hormones and therapy. We're working with a lot of foster children now, and it's very exciting because we're seeing some transformational results, and that was our goal. So our next goal is to expand our program and hopefully train teams, because I'm finding that as much as I love neurofeedback and working with it, working as a team with these people and their type of skills and them saying the same about me has really developed a program that I think is worth expanding to other individuals. So what we do is not unusual, and I just want to go over it very quickly. Integrated psychiatric solutions is really these three main components of psychopharmacology, which includes supplements. It includes all type of alternative combinations of medication, psychotherapy. There's probably not a therapy out there that at least one of us haven't used or tried or been familiar with. So there's a lot of therapy going on. Dr. Foster sees these patients. He sees his patients. He does therapy with them. He doesn't simply prescribe. And the neurofeedback component is which is the main emphasis of what I want to talk about tonight. But I really want everyone to keep in mind that it's the synergistic output is what I think is able to make a transformation for many people. It's not just about symptom reduction. It's about trying to help them make changes in their life that are long lasting. So in doing the symptom appraisal, these are the three of the main components. And once again, each one has many factions. I want to talk about a quantitative EEG. Many of you may have heard of it. Many of you may not be familiar at all. Please don't be offended if I make this, fairly straightforward. I don't know what everybody's background is. But with the children, Dr. Foster and I, we have weekly case meetings about every child we work with, about what they're doing with him in therapy, medically, what they're doing at most of these individuals that we're seeing now are in group homes because they've failed anywhere from 1 to 30 foster placements. These are what we call deep foster children, severely abused, severely neglected, and incapable of holding relationships pretty much with anyone. So we have to stay very closely aligned in how we view these individuals, and whatever therapy he's using and whatever talk therapy I'm using during neurofeedback is always to support what he's doing, and vice versa. So this cooperation, I feel, is exponentially more effective than what I could do alone or what he could do on his own as well. So wait a minute. These things, oh, okay, so a quantitative EEG is what I want to talk about now. And a quantitative EEG, or QEEG from this point forward, is an evaluation of the brain waves, just like you do in a hospital, in a neurological setting. I choose to use CAPS to do the acquisition of the brainwave recording. Many individuals still do individual placements on all 19 of these channels. I find the CAPS to be advantageous because they're pre-measured. So as long as I get a cap that fits the head correctly, and you can see there are different colors for different size heads, I'm able to get a very accurate assessment of 19 channels of EEG activity. So this is a sample and of a recording that's gone to a company called QEEG Pro. They're out of the Netherlands. So after I record these, I do my 10-minute eyes open, eyes closed recordings. I send the data, I email it to the Netherlands, and I get back about 200 pages of data. So every 10 seconds, this is approximately a 10-second recording, maybe 15 here, is put into the graphs. And you can see the different head recordings here, the different site of the head recordings from those caps that you saw in the previous slide. Now, this is a typical neurological readout, and neurologists are spectacular at picking up nuance and things within the EEG from these recordings. Where the Q differs from this is this data, this analog data, is then put into a database. It's converted using fast Fourier transformation and FFT that converts temporal data into digital data. And then we can get a brain map, as we call it. So we scan the brain, we get these brain maps. This is a sample of 1 page. This data is taken from that slide you saw. You know, it's the same data that you saw in the previous slide. And we see that we have different ways of viewing the data that comes in. We have what we call absolute power. That's the raw data that's plotted according to different brainwave frequencies, delta, theta, alpha, beta, high beta. I'm going to talk a little bit more about those in detail too. Then we have relative power. So in this particular case, we see that relative power, if you look up to the top, you see theta is the second from the left. And if you look down, you see that the posterior part of that topographical map, the rear of the brain, is 3 standard deviations. It's a Z-score of 3. So right away, we know there's an abnormal amount of slow wave activity in this person's recording. Amplitude asymmetry is not as always clearly defined. There's a lot of work going on with it right now. There's a lot of assumptions about how data is collected from the EEG and mapped. Typically, amplitude asymmetry may be looking at some sort of lesion or some sort of irregularity in the hardware of the brain. We have coherence and phase lag, which are connectivity measures. How well does the brain communicate from one place to another? We have hypocoherence, hypercoherence. Hypocoherence, well, we know that there may be difficulty with some kind of communication getting from one part of the brain to another. Hypercoherence may suggest that that the individual is stuck in certain brainwave frequencies that impede their ability to function normally.
No comment.
So another map of that identical activity is called a Loretta. It's a low resolution brain electromagnetic tomography. What this does is it uses a different technology to go into the looking for the origin of the EEG that you saw on the topographical map. So the topographical map is looking at how the sensor picks up data off of the scalp, which generally the scalp gets maybe 20% of the activity from pyramidal cells, summated pyramidal cells. So now we're trying to go deeper in what is they refer to as voxels. So a two-dimensional picture that you're looking at here is pixels. We've all heard of pixels. Our TV has pixels. Voxels are a three-dimensional cube, per se, array that is categorized here, looking at it. It almost looks like an MRI. It's actually co-registered with fMRIs and some of the other imaging techniques. Some of the research in here, researchers that put these all together just are really my heroes, because they've withstood the test of time. There's been a lot of debate about whether or not a quantitative EEG is a legitimate form of assessment. Once again, it doesn't, the QEEG is not used for diagnostic purposes. It's strictly used for mapping out irregular brain activity. Now, you'll see that in this pattern, we saw that the theta was 3 standard deviations, but yet when we look theta here, it's much less. So what we're realizing right away is that most of this aberrant behavior is much more cortical than deep. There's some deep generators, but it seems to become even more irregular at the surface. Those are the kind of things we look at with a quantitative EEG as a part of the assessment tool. So how do we use it in our practice? Well, for one thing, Dr. Foster has determined through years of reading the maps and looking at people's behavior and their response to medication, that he can look at a brain map and determine more particularly what will not be effective, as opposed to what may be effective. So we have, I think we're getting a little interference here. Okay, so for example, ADHD people, some have a very high theta to beta ratio. Theta being a slow wave, beta being a fast wave. A lot of theta leads to this distractibility. Stimulants generally do well because they turn on the left frontal lobe. It tends to reduce some of that theta activity, normalizing the brain behavior. Other ADHD individuals may have high alpha activity, and they will not respond well to stimulants, but they may do well to things like guanfacine, clonidine, mirtazapine, as well as they lower high alpha. So we see the alpha can go down. And if the individual with the high alpha is ADHD, may also have anxiety, it helps to do both of those things. This is just one quick example of how we go about using this. And then when he determines what medication will work for these individuals, we typically see that if he puts them on medication initially and they're able to start functioning, they're going to do better with their neurofeedback treatment. Typically, we'll use 2 to 4 weeks, of medication till it's pretty stabilized, the dosage particularly, and then we'll go into the neurofeedback. We also look at what types of psychotherapy can be chosen based on these quantitative results. If somebody has a lot of slow wave activity in the frontal lobes, or the left frontal lobe in particular, the slow wave activity could be disrupting information processing. They may do very poorly at cognitive behavioral therapy. But we may be able to do emotionally focused therapy, or some other type of mental emotional release therapies, or therapies that don't really involve a lot of cognitive processing per se. So we're also using it to look at what kind of therapy would be most effective. Also, the QEEG can be very helpful in looking at how we use neurofeedback. So Before we get into the more specifics of neurofeedback, we need to start with a review of biofeedback. And biofeedback is a technique to achieve voluntary control over physiological functions, which are normally regulated through the autonomic nervous system without conscious awareness. But we know, and I've given some examples here that most of you are familiar with. Really, a lot of it's a polygraph in biofeedback, right? But the EEG is also giving us feedback. And for some reason, the trade name neurofeedback was developed early on, I think to differentiate it from biofeedback. Whether or not that's important doesn't matter to me. I called it EEG biofeedback for years. Now I call it neurofeedback. It seems that neurofeedback nomenclature has really caught on. So what is neurofeedback? It's a learned response. I'm going to show you how it works in a minute. It does not require continued vigilance. I mean, the brain is really doing implicit learning. The computer provides information to the brain, and the brain picks it up very succinctly. What can neurofeedback affect? Well, it can affect arousal. The arousal model is one of the classic models in which we talk about neurofeedback. When we talk about sleep-wake cycles, circadian rhythm, many times individuals will have difficulty falling asleep, staying asleep. We see dramatic changes in sleep cycles, many times with neurofeedback. Cognitive processing, as in learning disabilities, there has been some success in those kind of areas. Sensory motor integration, learning to control impulsivity, moods, and even memory. So this training, I don't want it to look like a panacea, but once again, when it's used properly with the types of interventions that are being given with it, it can be a very valuable additional tool. So how did this all start? Well, back in the 60s, Dr. Barry Sturman was working at I believe it was Sepulveda VA hospital down in LA. He was doing a lot of research. And so he was doing operant conditioning of cats. And this was a NASA investigation because there was rocket fuel was being used for the jet pilots. And he was doing sleep research at the time. So NASA contacted him and said, hey, we're interested to know what happens to our pilots if some of the monomethylhydrazine gets stuck in the cabin and they start to breathe it. Excuse me, I'm bouncing around here. So he said, well, why don't you give me some of this jet fuel and we'll see what we can find out. So in the meantime, he's studying these cats and he's looking at sleep and how does sleep occur. And he was looking at the internal inhibition of cats. He was trying to see if operant conditioning could make the cats go to sleep. Could he condition the types of brain waves in cats? Now, remember these, not remember, but I'll let you know that these sensors were right on the cortex. So this wasn't surface electrodes. These were deep-seated electrodes right in the sensory motor area of the cat's brain. But what he noticed was during these internal inhibition experiments, instead of the cats becoming sleepy, they became very alert. And they produced this new rhythm over the motor cortex of 12 to 15 cycles a second of brainwave activity. He called it SMR for sensory motor rhythm. So he trained these cats with these sleep experiments, and they created this SMR, operant conditioning feedback, where their brains were making more of this activity than other cats. Now he exposed them to the jet fuel. And Woody, and they exposed him to the point where they would go into seizures. I mean, this was serious research back then with regard to how are humans being affected by this. And so what he found was there was a huge latency in the individuals that had done the SMR conditioning. They either had lower seizure, higher seizure threshold, or they didn't have a seizure at all. Okay, they were more resistant. Some of them remained seizure free. And he thought, gee, this is interesting. And, you know, so it was one of those scientific experiments where you're looking for one thing and you find something that ends up being totally different than what you're looking for, but yet very significant. So he published this clear data that brainwaves could be operantly conditioned, and that was in 1967. So a meta-study in 2000 for epilepsy suggested 82% had a significant seizure reduction, et cetera here. And, you know, 5% had complete control. So yeah, is EEG neurofeedback used for seizure amelioration? Sure. We need more research on specific training for specific types of seizures. I think that would be the next step. So from that, we realized that there are a lot of disorders that may be categorized as minor head injuries. You know, it may not be something that's diagnosable by current standards, but that they have this dysregulation in their brain. So now, all these years later, we're finding that the clinical applications of neurofeedback have a pretty wide range of support. Once again, we're not saying we cure these individuals, but we definitely improve their symptomology. And as I tell individuals that come in to see me with some of the more significant presentations, Tourette's, mood disorders, et cetera, if we can make a 20% change in your behavior, in your symptomology, that's life-changing. So I'm always trying to be very realistic with individuals. Although with things, with conditions like ADHD, we're seeing 70% reduction, and sometimes even more. There's a lot of things listed here. And without going into all of the applications, I've listed a link for a comprehensive neurofeedback bibliography for those of you that are interested, because I know not everyone's interested in all of them. And probably somebody's interested in, all of you are interested in at least one of these, is the way I'm hoping that you'll maybe want to take a look at some of the articles in your specific area of specialization. But if you think about it, the central nervous system really affects just about everything. And we have found a way to non-invasively help the brain find homeostasis. We're trying to help the brain find the resources that it already has for whatever reason that it's not able to use them. So how does this neurofeedback system work? Typically, the standard system has a computer and a monitor, which has games on it. The clinician computer and monitor shows a live readout of brainwave activity. And the sensors are placed on the client based on all the information we just talked about. There are different trainings for different outcomes based on where you put them on the scalp and what frequencies you ask the brain to attend to. Now, you're not putting a signal in. It's done through this feedback, and I'm going to show you a little bit about that too. So brain waves are very interesting. They're a millionth of a volt. So they're so tiny, we can't even see them without an amplifier to collect and process the signal. So one of the things that became very clear early on was the quicker the feedback is to the screen which the individual is watching, or the auditory beep, which is a signal saying your brain's making adequate compensation for what we've asked it to do, the better the result. And so most of these systems are set up to provide feedback in less than a second to what the brain has just done. So it's real-time feedback. This is how a system looks. Now, I don't allow, or I don't encourage my clients to look at my screen. I encourage them to look at a game screen. So this young child here is looking at a game screen. Okay, behind there is a therapist monitor. In between the two computers is an amplifier. Now, there's amplifiers half the size of that now. The original amplifier I had in 1994 was half the size of this laptop. So, you know, we've come a long way with technology, and it's wonderful because when I first started teaching in 2003, let's say we were in Boston, they would fly one system for every 2 people. So if we had 40 people in a class, 20 systems, 2 computers. For each one, we had to set up 40 old CRT desktop computers to teach the course. The interactive games are to keep everyone interested. Most people don't want to look at their brain waves when they're doing this. They want to kind of get into the zone of looking at some kind of video representation of something they're familiar with, a game. The game is independent of the feedback because, you know, the therapist sets up the feedback and they can choose whatever game they want and it'll respond according to how it's set up. It gives variety. We have a variety of different games to keep them interested. So we choose a game typically based on age, interest, you know, those kind of things. This is one of the first original games. I love this game. It's still a very, very good tool. I still use this every day. It was developed in 1988. It was developed by the son of the authors who started a company called EEG Spectrum. It's now referred to as Eager, EEG-ER. They've gone on to develop another system, and this was developed by their son, who was a seizure client of Dr. Sturman's at UCLA. And so when they were developing these PC software programs, this was one of the first games they developed. So what happens is, as the individual meets the threshold for the variables the therapist sets up, then Pac-Man moves through the maze. If they start to get off of those thresholds, which I'll show you in a second, then Pac-Man turns black and slows down. So in essence, the individual is training their own brain. This is another game which has 3 variables, purple, green, and yellow. And you tell the individual, okay, I want you to keep the green ship in front of the other 2 ships. So we're giving them information. If you look on that screen, you'll see that the purple and yellow have a thick gray component at the bottom of those bars, and the green one has the gray area in the top. So we ask them to try and keep the green bars in the top and try to keep or suppress the purple and yellow bars down into the bottom of the screen where the gray is. So the instructions are relatively simple. I usually tell them, focus on one thing, focus on the green ship, look at the jet fuel, you know, et cetera. The brain is picking up all the information much beyond their conscious appraisal of what's going on. After training them for several sessions or even more, they do start to connect what they're doing with what they're seeing. And they'll say, oh, this is too hard today. This is too easy, Dr. Finnick. Make it a little harder for me today. I want to be more challenged, or I want to get more points. So they actually become very interactive with this implicit learning. So this is what I look at when they're looking at their screen. The top channel is what we call the raw EEG. It's the entire spectrum of frequencies from 0 to 40 cycles a second. So below that, we see that there's an inhibit band, a reward band of frequencies, and another inhibit. So once again, the purple and the yellow then are these two inhibit bands. And I said, keep the waves low. Suppress that activity, because we're trying to inhibit slow and fast waves here. The mid-frequency waves here, 15 to 18 cycles per second, we're trying to enhance. So we're trying to reduce the harmonies, the background music, the slow waves and the fast waves, the treble and the bass, and we're trying to increase the melody. We're trying to get the brain to bring forward this specific set of frequencies into the foreground, because it's an activation of those waves. Their brain starts to pay more attention to them. Therefore, move the green ship forward, enhance this reward frequency. So this is why the graphic interface was introduced. Now, personally, when I want to do some neurofeedback training, I just look at the waves and tell myself, make less of this, make more of that. Some people really like looking at brain waves. I happen to be one person that does, but I don't expect everybody to, get their jollies looking at sine waves. So when we look at a state of arousal and wave patterns, we see that when the brain is excited, it becomes as it becomes more activated, excuse me, it becomes smaller. And that's because as the brain waves are the summation of action potentials, neuronal action potentials. As they synchronize, the brain waves get bigger. So when we look into alpha here, we see a relaxed state and a theta state, a drowsy state. We see that the waves are slower. By that we mean that there are less of them per linear inch, okay? I included some of this, but unfortunately it's in the wrong place in the slide. If anybody has any questions, please feel free to ask. So when we see a lot of activity here, we know that the brain is synchronized. They're summating and they're firing in unison. That's what happens as we get into a relaxed state. And if you think about it, a relaxed state means you're not in this motivational or anxious or high thinking state. You're more into a state where you're paying attention to a wider horizon in your environment. You're not focusing on a page. You're maybe focusing on an entire landscape or something like that. We'll see that there's more of these action potential summating. When you have to do a mental task, reading, writing, arithmetic, each individual portion of the beta waves has a specific task. And so they become smaller because each of them are functioning independently. As we get into drowsiness and sleep, the pattern changes again. You can see that the deep sleep is very large. And at that point, most of the cortex is pretty much shut down from conscious activity, fortunately, right? And we're also immobilized, except for those that sleepwalk. So a small EEG is normal. That's what we're looking for. When we see some of these larger EEGs, we go, we've got to try and figure out what protocol, based on what we looked at earlier, would help this individual to get their brain more in tune. Now, it's not always that we see this bottom trace turn into the top one, but we do as much as we can to teach the brain how to become activated through this feedback process. or in some instances, how to relax. So there's right now, there's three main types of neurofeedback. The SMR beta training, the alpha theta training, and this QEEG based training. Now, I'm going to jump ahead here and come back, and I apologize for that. So let's review some of our basics. Just, a hertz that I've been talking about is an entire upward and downward cycle from A to B. That's 1 hertz. So if I talk about 14 hertz, this is what I'm referring to. A frequency is how many of those hertz occur in a second. So we have 8 cycles, we have an 8 hertz signal. That is the frequency is how frequently it occurs. Amplitude is the measure of power, how high and low the sine wave goes. How many microvolts is it? And that's what the amplitude measure is. So when we go back to this page, we see the SMR beta training are those mid frequencies, 12 to 20 hertz. We can pick the SMR, or we can pick a little higher beta training. If we're going to do SMR training, classically, typically, we're using right hemisphere because the right hemisphere mid-dominant frequency is actually lower than the left hemisphere. So if somebody comes in, they need to be calm. We might do right hemisphere with an SMR reward while we're inhibiting those excessive slow wave activities. If they're having trouble focusing, we might do beta training, which is slightly faster, 15 to 18 hertz. That would be on the left hemisphere, the training. And it's teaching the brain through feedback where to activate the brain for more focus, as opposed to being calm. When I'm talking about calm, I'm talking about where the body becomes calm. And in many instances, when we calm the body, we don't need to do beta training for focus. The beta training was there, the anxiety or the high level of functioning in the right hemisphere was disrupting focus. So we've, through neurofeedback, I've learned that I can calm somebody to increase focus as well as activate to increase focus. And this is where the clinical skill is required. Now, the alpha theta training are slower waves. Alpha is 8 to 11, theta is 4 to 7. So now we have less sine wave activity per second. This is done with eyes closed, because when we close our eyes, there is an immediate increase in alpha activity in the parietal lobe of the brain. It's the beginning of relaxation. Before unless you pass out, none of us go from an awake state to sleep, right? We have to relax. So alpha is the first visible sign that we're starting to relax. We can see anywhere from 2 to 3 times the amplitude of alpha in the parietal lobes just by closing our eyes. And what we do is we'll ask a patient to sit in a chair with their feet firmly on the ground, to be grounded, and there'll be instead of it being feedback in the form of a beep and the visual points, as we saw in the first particular example there, there'll be sounds. There's a creak sound when alpha is being enhanced. There's an ocean beach sound when theta is being enhanced. And for any of you that have sat on the beach and listened to the ocean, I guarantee you were getting in a theta state. And that's why we flock to the ocean and try and be quiet and calm and feel like we're one with the ocean. That's the theta experience. So we're trying to emulate that. There's been a lot of research on addiction recovery with alpha theta training, particularly inpatient. And then there's also QEEG based training, which is done on those Loretta, off of that Loretta information that we looked at earlier. So the SMR beta, once again, it's a focused on stabilizing or activating and calming the motor system of the brain. It's improving inhibition. 90% of what the cortex does is inhibition activity, inhibitory activity. So, that's why what we see in our jails are people that can't control their inhibition, right? So all of us have this excitatory activation out of our brain. Our cortex works to inhibit it. That's why we train children. We're training inhibition. Nobody has to train a child to yell. You got to train them to stop yelling. So that's inhibition. Once again, it was first used with epilepsy, and now there's quite a wide range of disorders that have proven to be fairly efficacious. And once again, I listed comprehensive bibliography. The alpha theta training then started with this research around alcoholism. Well, actually, the foundation of it was at the Menninger Institute in Kansas. Some of you may be familiar with that. Albert and Alice Green, well, the Greens, worked on what he called a state of revelry, and he would enhance theta in the occipital lobe and put people into an extremely deep state of relaxation. So what do we know about things like addiction? High correlation with anxiety. So when individuals that undergo treatment with the alpha theta protocol, what Eugene Peniston found was that it replaces their endogenous endorphins, enkephalins. So once that occurs, then the alcohol isn't necessary. And the cycle here is, as you drink alcohol or take drugs, you're increasing the brain's, you're synthetically activating these activities that make us feel relaxed, right? That's why we have a glass of wine, etc. But in the case of alcoholism, the alcohol actually replaces the natural state that you would get into when you're relaxed, which is an alpha state. The only way you can get into alpha now is to drink, because you've eliminated the brain's ability to do it naturally. So by enhancing alpha and hopefully getting them to relax enough to get into a theta dominant state where the amplitude of the theta is actually higher than the alpha, they're chill, they're very relaxed. And subsequently, the cravings go away because the brain's starting to create its own ability to alphatize. All right. So it helps stimulate this imagery, and that's all part of the theta state where creativity takes place. And it helps to process deeper emotional issues. And that's also why some people have chronic, addiction. They don't want to deal with some emotional issues, trauma. A lot of this work was done with, PTSD individuals, military type of PTSD, and there's been some very good success with this. It needs, at this point, we're finding most of the success comes from inpatient, where they're in there 30 or 60 days and they're doing this training every day. The beta SMR training, I find, works best if you do it a minimum of every other day, a maximum of every other day, once or even twice a week. The brain needs to sleep after it does this learning. It needs to consolidate learning. The alpha theta is just a relaxation training, can be very powerful. However, for most of the individuals that are traumatized or are having trouble with addiction, we do the beta SMR training first before they can even get close to doing this type of training. So it's a very complex procedure. But more and more people are becoming aware that this is the real deal and that it can really help these kinds of people. Now I'm seeing there's a couple of questions. Are those questions in the chat box? I don't have it. Oh, okay. Here it is. Does it matter if a person is left-handed? That's a great question. To date, no. I used to teach neurofeedback, and one of the other professors was a neuropsychologist, did his dissertation on left-right hemisphere differences, and said that this particular behavior that we're seeing is not dependent on handedness. Does hypnosis have to put people on theta state to be effective? No, it's more of a hypnagogic or self-hypnotic state, and they're aware that they're in the room. They are definitely aware that they're in the room. However, time becomes something in which they are unable to keep track of. Time is irrelevant. I'll say, they'll be under for 45 minutes listening to these. And the alpha theta training is a crossover training. It goes to where people will, their amplitudes will cross over between alpha and theta. And there seems to be a lot of emotional release in that crossover area. So they'll be going back and forth. And at the end of 45 minutes, I'll say, how long did you think this lasted? Look, I don't know, 5 minutes, 10. So we know they're in that state where, conscious awareness of time, et cetera, cognitive things is really diminished. Okay. Oh, let's see now, okay, here we go. So the QEEG based training is different in that you're using the full cap much of the time, or maybe 3 or 4 channels hooked independently, but a lot of people are doing what they call full cap 19 channel training simultaneously. Now this training is based on the Z-score feedback that we saw in those earlier, like Loretta maps. So you're either increasing or decreasing Z-scores that are 2.5, 3 standard deviations from normal, trying to stabilize the nervous system. Pardon me, this is a newer form of feedback. I mean, it's been around from the 90s, but once again, the other's been around from the 60s. I've had some training in this. I administer QEEGs. At this point, honestly, I haven't done full head EEG training. With the population I work with, these extremely delicate nervous systems, I do 1 channel of training, which means I have 2 ear clips and 1 sensor on the head. And the reason I've chosen to stay with that for this population is that these nervous systems are so fragile that it's, in my opinion, the least invasive way to help them gain control of what's going on inside their head. An example would be a young man that we're working with in our clinic that had severe neglect, heroin parents living in motels, severe abuse, were taken from parents, failed foster placements, went to live with his great aunt, with whom he developed a relationship, fell in love with, found her dead on the floor at 6 years old, had to call 911. Well, from that point on, things went south. He ended up, after about 15 failed placements, in a group home. And at 8 years old, we started working with him about a year ago. He's still in a group home, but he is making a transformation. He is going through some developmental stages of 4, 5, and 6 now. And we really feel within the next 6 to 9 months, he will more than likely be able to hold a foster placement. Will neurofeedback interfere with someone that has a cochlear implant? Another really good question. If you get too close to it, it might. Most of the time, you're not training directly behind the ear. The closest typically we come is the temporal lobe or higher in the parietal lobe. We would have to make an allowance for that. We're only looking at frequencies between 0 and 40 hertz, so I'm not familiar with the frequencies of a cochlear implant for the purposes of auditory information processing, but I'm sure that they're, well, I'm a little bit familiar. I built speaker cabinets. I used to be a sound technician many, many years ago, but those frequencies are typically above what brainwave frequencies are. And that's why the ears are used to interpret frequencies to the brain. These are great questions, and I appreciate them. At least I know that, you know, we're still here and interested. Okay, what I have here is, this is from many, many years ago. And this was not my patient, but it was a patient of one of the founders. And this is a drawing of a child who started neurofeedback, 9 years old, not too good. You know, stick figures at 9 years old. This person was definitely functioning below age, chronological age development. This is after 4 months of neurofeedback, same individual, quite a dramatic change. In child 2 here, we see a family drawing at the beginning of neurofeedback. I don't recall what the age of this child, but to me, it doesn't matter what the age is. This is after 20 sessions of neurofeedback training. This is after 40 sessions. So what we see over a matter of months, some individuals are able to access the resources that are already there. Neurofeedback didn't create this in his brain. Neurofeedback allowed him access to it. And that's one of the things that we always, you know, try to remember in our clinic is these individuals, you know, with the exception of a TBI, have the resources, they've just been derailed. So we're trying to put them back on the track. And we do it with whatever means possible. The more a person is under medical care, and you know, that's the reason I drive down all the way from my home to do this and work with individuals who support each other, is that, you know, you can see very dramatic effects from these types of things. So we went over that. And well, I'm sorry. The rest of these slides really are just part of what we've already talked about. I did just want to show you a spectral display, which means if you look along the x-axis here, we have hertz, frequencies, and then we have time on the right-hand side in seconds, and then the colors of the different frequencies, the bumps, are then the amplitudes. So we see in a dysregulated brain, when we look at the entire thing from a spectral array, we see that there are a lot of slow wave activity going on here for someone who's awake. Here with eyes open, this particular individual still isn't as alert and awake as they should be. And here is a nice, smooth, normal, awake state. So that is some of the things I just wanted to cover today in a sample of what neurofeedback is. Somebody said, what do you think of brain SPECT scans? Oh, we got a bunch of questions here. Great, I love questions. Lots of questions, not as many answers, okay? Let me get back down here on the questions here. Okay, what do you think of brain SPECT scans in relation to cognitive function of the brain? We see a lot of people, you know, being here in Northern California, a lot of people have gone to the original Clearfield clinic for Dr. Amen. I heard him talk in 1994. He has neurofeedback in many of his clinics now. The SPECT scans can provide information. It's not necessarily information that would help me develop a protocol, but it might help me to understand if somebody has a ring of fire, they're bipolar. Well, if I'm going to see somebody bipolar, I'm going to be training left and right temporal lobes, or the juncture between the central and temporal lobes. We have found that communication between left and right hemisphere needs to be augmented through feedback, and have actually seen some pretty dramatic results with some bipolar individuals. Some stay on medication. It's usually less than what they started with. A few have even gone off medication, which is not common. So I don't take credit for this. I give the credit to the individual's brain. I'm just trying to help their brains do well. It says, is a neuroquant helpful to you? I'm not sure what that is. If you'd like to respond back to tell me what a neuroquant is. If you're talking about a QEEG, yes. If there is something specifically called that, then I'd like to be more familiar with it. The impact of heavy metals, pesticides, malnutrition, yes. Medications, etc. There are biomarkers for all those: heavy metals, pesticides, malnutrition, and a QEEG or even a classic raw EEG can detect a lot of those. If I detect something significant in that raw EEG, then I'll refer that data to a neurologist who is also a practicing quantitative EEG clinician. And there are a few of those that we use as consults. I also consult with some other individuals as well. Interesting meditation and those types of activities. There was a study done by Tom Hart, who did some research on alpha training back in 1993. A very interesting individual, to say the least. He left San Francisco for Canada because he said San Francisco was too restrictive for him. So that gives you an idea who this gentleman is. Fantastic researcher. Did some research on Buddhist monks during meditation, watching them get into full alpha and theta states. And what they responded back to him was, it was interesting to have information that led them back to the same place more consistently. So there's that type of feedback that we receive from them. So yes, we have seen some improvement in meditation. I don't know Joe Dispenza, but I believe, I've heard his name. I think, is he in Colorado? I believe I've heard that name mentioned. There's so many people, and I used to feel like I knew everybody, but everybody's a lot larger group now. So I believe, let's see. I believe I've covered what I wanted to cover. So if any of you, have any additional questions, would like to ask me anything, I'm happy to try and answer it.
Thank you very much, John. It was really terrific. I had no idea that's what you were doing. That's what you did. So you're always quiet when you're around here.
I wonder why.
So, a lot of the work that I do deals, with hormones, and we deal with a lot of brain injury folks, because a lot of the behavioral issues that we see actually have a hormonal component to it. Do you have any insight at all as to what, what kind of changes you might see with the neurofeedback at all, or not?
I'm sorry, insight with regard to what, Bill?
So,
With
a person comes in, they had a head injury, and they're fatigued, they have depression, they have personality changes, they have they'll have substance abuse issues, fairly typical, chronic long-term depression. Medications don't seem to help very much. We do our hormone panels, and we frequently will find low testosterone, we'll find low growth hormone. Sometimes we'll find some autoimmune issues with it. We sort of tune those up. That's as far as I go. Have you looked at anything along those lines as far as, with your neurofeedback?
Sure. Yeah, I've worked with TBI for many years.
Okay.
And I can tell you that I never know how each individual is going to turn out, to be honest with you. Some people that I had, I don't want to say little hope, but the prognosis wasn't high. I worked with a young girl many years ago who had a right frontal tumor that was removed at 3 or 4 years old. And the surgeon at the time said, well, luckily it's the right frontal lobe, you probably won't notice much. And I told the mom, I said, look, there's no empty space up there until you create it. I mean, everything's going on at once, and it's important. And I proceeded to describe the types of behavior that she had difficulty with, and impulsivity, and emotional dysregulation. And she said, well, you just described my daughter. Well, yeah, she had a tumor in an area where a lot of that processing is happening. So we did some neurofeedback training, and every year that she went back for her classic and EEG, it showed epileptiform activity. A year after neurofeedback, it hasn't shown it since. So we're able to say, yeah, we can do some things. With the symptoms that you just mentioned, this is so common. Depression is almost guaranteed with TBI, because when any part of the brain is injured, we see an excess of delta and theta activity. The brain, let's take a car accident as an example. The frontal lobes hit the windshield. There's some shear wall activity in the brain. We know that those cells have been compromised. The first thing that happens when cells are compromised is the brain goes into this sort of not recovery mode, but I'm trying to think of it goes into survival mode. So it shuts down some of that conscious behavior. People go into a coma. One of the founders of neurofeedback did some studies on coma, trying to pull people up on their scales, the coma scales. Margaret Ayers, a brilliant individual. So we see this slow wave activity that creates a state that an individual would be in when they're depressed. So now they're forced into a depressed state as a result of the injury. So now their brain's acting like it would be when they're depressed normally, but they're not. It's not a normal depression. It's a biological insult to the brain. So we can, with the advent of the Q, go in and take a look at where is this activity occurring and try to help the brain self-regulate as best it can. We're not going to regrow brain damage, we're not going to fix damaged cells, but there is some compensation that can occur. And this is where I tell people often with severe brain injury, a 20% change in brain function is going to change your life. It's not going to go back to what it was, but it's going to be a heck of a lot better than where you are now. And so we have been able to see that. It's a
Mhm.
tough group. It's a tough group. I'm not going to paint a rosy picture.
Mhm.
It's a difficult. I think the hardest part is getting people to continue coming in when they don't feel like they're getting any improvement, because one of the things that TBI does is make it hard for people to, for many people to, with, strokes and TBIs, is to notice a change in their state, their arousal state, or their brain state, or their functioning state. They really need a third party to say, hey, you know what? 6 months ago, you couldn't fix your own meal. Now you're cooking. They're like, oh, I didn't. And so it's a long process, but there is a lot of hope for that, especially when they're getting the kind of care that you're doing before they would ever come and see somebody like me. Because without that foundational work, I'm wasting my time, to
Well,
be perfectly honest with you.
yeah, you get the end of the road folks too. I mean, it's not a usual thing that they'll show up here. So we we have in our sort of database changes in hormonal activity within 96 hours of a mild traumatic brain injury. Almost in men, almost 95% of men have a drop of up to 50% of testosterone within the first 96 hours of a mild traumatic brain injury.
Really?
Yeah. And then long term, 30% within 3 months, if it's not addressed, 30% of the mild traumatic brain injury patients have some sort of growth hormone deficiency. And within a year, it actually goes up to about 40%. And they have deficits in things like executive function, which is memory, concentration, starting projects, multitasking, obsessive compulsive tendencies, those kinds of things. And so that's what I'm looking at.
Yeah, so then the first thing that comes to my mind is that the nervous system feedback, let's say from the thalamocortical feedback from the cortex to the thalamus, right?
Mhm.
And then down further to the hormone glands, right? The hypothalamus, et cetera, is not functioning. So if you're not getting good feedback to the thalamus and then to deeper subcortical regions, then those areas are going to just stop producing. They're, they may think that the individual's asleep all the time, and
Yeah.
or some other type of
Well, those structures are
feedback that's
easily
not there.
those structures are easily injured. The hypothalamus has just only two very thin nerve fibers that feed it, and there's no blood supply. And the pituitary has two very tiny arteries. And when you shake up the brain, it's easy to tear all of those structures. So,
Yeah, and then the brain stem has a limited number of neurotransmitters,
right.
As well. So
So,
that's why I say I try to be very realistic.
mhm.
Depending on the injury, sometimes we can help compensate for that, and other times we cannot. Another question is, do you have any device that you recommend to use at home for brainwaves for personal use? The Muse, I believe it's MUSC, seems to be fairly well put together as far as the research behind it. One of my colleagues is on their board, Dr. Norman Deutsch. He's a psychiatrist out of Toronto. He wrote a book called The Brain That Changes Itself, about brain plasticity. And if he's on the board, usually he's pretty conscious of being around good things like that. It's MUSE, I believe, the Muse.
Could you type that in the chat, John? Because I'm having a little hard time hearing.
Okay, somebody put it in there. Yeah, The Brain's
Oh.
Way of Healing by Norman Deutsch. Yeah. And
Okay. Great. Okay. And then the next question was about any supplements for brain health.
Excuse me. Yeah, you know, I leave that up to Dr. Foster. And so I can't really give you a specific supplement. I know that, you know, he has a list a mile long of things I've never even heard of, and some of them I have. He's probably, if you would like, what I'll do is I'll talk to him about that and I'll email it to you.
Okay, and talk to him about maybe coming on here also.
Sure, sure.
Okay.
Yeah.
All right. So I know in the again in the traumatic brain injury world, we'll use things like coenzyme Q10 with PQQ for mitochondrial resuscitation, adequate vitamin D, omega-3 fatty acids, particularly the DHA portion. Those are just off the top of my head.
Yeah,
And
I've heard about all those. I've seen all those in charts in our office as well. Methylfolate,
mhm.
you know, he does a very similar panel and really looks at, you know, without fundamental biology, everything else is a skip and a chance, right?
Mhm.
Now, somebody's asking about plasmalogens. They may be asking you. I'm not sure what that is.
Yeah, I don't use them. So yeah, we had a lecture on that a couple of weeks ago. So
Oh, okay.
again, another one of those a little bit esoteric, pretty interesting. And I'd have to go do a much deeper dive before I started you know, recommending it at least to our patients. So
Yeah.
okay,
Well, you know, I find, pardon me, I find what you and your colleagues here are doing is so necessary for anybody like me to get any kind of decent result with what I do. I mean, from the beginning, I always, you know, insisted that people had back then, even just a medical checkup to rule out, you know, generalities of 28 years ago. And then slowly became much more aware of what is called integrative medicine now, which is big on my list of things to learn more about and understand because it helps my patients as well.
mhm. Anybody out there in Zoom land, any of you use the plasmalogens? Let us know. Okay, and then one of our other, he's not on tonight. He's big on intranasal oxytocin for pain management and all sorts of healing properties. And any experience with that? Any of those things, John?
Not directly, no.
Okay.
No, no.
Okay.
I've worked with some pain people, but it's not really been my specialty.
Okay.
It's more
Okay.
default. Well, hey, this guy does biofeedback in Tahoe. I have back pain. I'll go see him. And, you know, some have been okay and some have not. That's a whole separate specialty in my world. I mean, that's the toughest one of all. To me, is chronic pain.
May I speak?
I was getting to you, John.
Well, Dr. Finnick, I made a movie about you this afternoon. It's 1 minute long, and it's a 1 minute intro to our show tonight. Bill's going to send you that, or somebody will. And so I wanted to just thank you for what you're doing, but see also the artwork we have in this video we're sending you, and see if we might have some common path in sharing information here on what you're doing, because it relates with electromagnetic fields around the body, that type of thing, exactly what you're doing. And I just would love to share the info you're doing. And I think you may be doing some of the work that I see curing incurables. we're dealing with a couple of veterans. And just by doing a few simple things with neurofeedback, they've made more improvement from that than any other therapy in the last 10, 20 years. And one of the comments I hear is that, you know, for some reason, I'm going to sleep now and my brain feels normal.
Yeah.
And my pain has reduced. And these are hardcore cases I personally know. So I think you're dealing with something very important, and I'd love to share with it if we could.
Yeah, I would love to. And, you know, maybe I should put my information in here, huh? As
Put your
well.
information. So John, you said you do training classes?
I did for
You did.
many, many years, and I'm in the process of considering doing them again. I love doing trainings for this. And Dr. Foster and I are really, you know, looking at developing a training together for, you know, looking at everything we do, not just neurofeedback, but I'd be happy to put trainings on.
Well,
I'm
you know,
still-
it's a lot easier now we have these devices here. You can actually record, you know, just hit a button and it records it, and you're good to go. So,
yeah.
what kind of training would one need to I mean, is there a certification? Is there a you know, do you need a PhD for this kind of work?
No.
I mean,
Typically, it's an MA level training to buy equipment. You know, it's all based on equipment purchase. Almost all trainings are from the people that make the equipment. So if you want to do Z-score, you go to the guys that teach Z-score, right? I'm using a system called Eager, and it's been around, you know, for many, many, many years. I know all the people in the company personally. I did teach for them. That screen that you saw with the therapist, the EEG screen, there's not a lot of them that can replicate that clarity, that real-time information. I'm looking for it again here. I want to pull it up. There were two men responsible for this. The first one, Ed Dillingham, was back in the 80s. He worked for Hughes Aircraft, and so did Siegfried Othmer. And Othmer convinced him to develop a screen at looking at real-time data. So if you look and you see the red vertical line, it sweeps across the screen in real-time data coming across there. So, you know, if somebody moves their shoulder, I see it. If they blink, I see it. And so it's a very well-designed screen. And a lot of people say, well, that's, you know, that's not as necessary as just putting in the parameters. But for me, I want to see what they're doing while they're watching that game. And anyway, yeah, there's all different kinds of opportunities that, you know, can be considered for training. Typically, like the Eager people want you to be trained to buy their equipment. They offer an online course taught by somebody else. They did talk to me about creating another online course, but I'm going to be creating my own with Dr. Foster. And if they're willing to allow people to buy it, it will probably be, if I create it, once again, I created the course I taught for them from another course. And I got board certification, biofeedback certification, the BCIA, Biofeedback Certification International Alliance. And if I get that, then, you know, they're going to be willing to allow people to purchase their instrument. I call it an instrument because you have to learn to play it. And yeah, I put, that's the wrong, you know, I'm trying to do too many things at once here. Let me put my email in here again.
Mm-hmm.
It's Finnick, 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 Finnick
I have about 100 questions after hearing this talk.
Oh, well,
And
you know
some,
what? I'd be happy to, meet with you at another time and converse.
let's do it, because only recently we've stumbled into artificial intelligence with image creation, which is what I do. And then I thought the materials we used would make me dumber and less of an artist because I'm not drawing enough, right? But by using the artificial intelligence programs, my ability to see and think has improved. It hasn't reduced, it's improved. And I'm
Ah.
wondering if artificial intelligence tied in with visual and words and whatever else we're doing has an improved effect. It doesn't make us lazy, it makes us smarter. Maybe.
I hope so. I'd like to think that the last 28 years was a very valuable usage of my time. And I see that, there are many different forms now of, there's a lot of people calling things neurofeedback that are similar but different, and the fields are growing, and I think it's very exciting.
Yeah.
I know that there's, like Elon Musk is working on implants and those types of things, which we hope are to help us move our limbs and not transfer our data per se. But I think that, all of these activities in AI are probably where neurofeedback was 20 years ago, and so we were there, and now, people are thinking, well, we're moving beyond that, but we're not. This is still very, very, very important information that's helpful. You don't get rid of something because something new comes along, you add to it.
So what would a setup like yours cost, John? To set up
Well, when I started, the system and the training was about 30,000. Now it's down to about, for this system, you could probably get into this is a very pricey system, but it's probably around maybe 4,000 to 6,000. And most of that is for the, the software. Brainwave amplifiers are still relatively expensive. And, your computer cost is not very high. That's the least amount of it, right? It's the amplifier and the technology that you're buying, and the support for the
So
technology.
what would the cost to a patient be? Or is this an insurance thing, or how is this?
Yeah, good question. It just depends on how it's billed. Some people bill under psychotherapy. Most people that I work with who are not part of these county contracts for group homes, private pay, I charge $120 for a half-hour session, which is usually 45 minutes, $180 for an hour session, which is usually 75 minutes. Or they usually come in once to twice a week. Outpatient, it's hard to really get somebody to come in more often than that. And that's about the standard for this treatment. It's similar to a therapy.
Okay. So is this a labor intensive for you, or can you train an assistant to run the machine, and then you can read the scans later? Is that a way to go, or no?
It is. I've had a technician in the past. It's definitely a way to go. What I would, there are many different disciplines that use this, chiropractic, yourself included, DOs. When I trained people, I trained people from every discipline of health there is. They would come to these classes. I had an ER physician who transitioned into doing this in a practice. That's quite a leap. I think that, if you want to do this work, the more you understand and teach yourself about neuropsychology, neurophysiology, and all those disciplines, the more you're going to be able to understand how this person's going to respond.
Mhm.
But,
Are-
you know, it doesn't mean you have to specialize in those. You know, I had to teach myself all this, and my background in psychology and assessment was obviously very helpful. My background as a sound technician was extremely helpful because I understood a lot of what you're looking at on the screen here before they even started. It's like, oh, wow. You know?
John,
And so,
are you familiar with Quiet Mind Foundation in Marvin Berman, PhD's work?
I've heard of it. I'm not, you know, intimately familiar with it at all.
Because he's got technology that can put a unit in for a clinician or a patient, you know, under $2,500.
Okay, and it's a neurofeedback, or they're
Correct.
calling it, okay, Quiet Mind,
Quiet Mind Foundation.
okay,
Marvin
and,
Berman, Berman, PhD.
okay. Yeah.
They're in
I'll-
Pennsylvania.
Oh, okay, okay, That's
Just
great.
one of a number of companies that are out there that have this technology. I was exposed to it in a functional medicine clinic back in 2012, and it was remarkable for kids to improve their physical activity, their cognitive performance in school, athletics it was used for, and then the standard OCD, ADHD conditions.
okay. You know, a lot of these instruments have come down in price and are still of very high design quality.
Yeah.
Typically, the lesser ones were limited in what they could do. It was like presets. They were preset where I can manipulate everything. But I would definitely look into that, because we're looking right now. I'm looking at. I work with a corporation that has 4 group homes. Almost all of them are 2 hours from my office, and they'll drive one child 2 hours for an hour session and 2 hours back.
Oh, that's rough.
It's rough on
This may be
everybody.
a wonderful opportunity to help both the patient and you guys out.
Yeah, my goal is to have a system in each group home, and then they can hire med techs to hook them up, and then I'll do the session remotely.
Perfect. Yeah.
And we're looking for like this. We're looking for something that's feasible. And then obviously then, you know, I'll train the tech and, you know, make monthly visits in person and do the other sessions remotely to keep them learning and doing this. And, you know, we're starting to see such good results. We are looking for grant money. If anybody knows of some foundations that might be interested in this, because we eventually want to train other psychiatrists and psychologists to work together, because as I said earlier, it you know, with these really challenging individuals who have really had a bad start in life, you know, we want to help them turn that around. And it's very labor intensive, Bill. It's really intensive, but it pays off. So, you know, you don't care how intensive something is if it pays off. It's only when you feel like you're doing all this stuff and nothing happens. But we're seeing great things happen. So we're very excited to move it forward.
We don't know anything about doing labor intensive stuff and not paying off, do we, John?
No.
We're experts. Hey,
I think we invented it.
I think you and Dr. Finnick are going to be world famous dudes. So
Yeah.
just took you 50 years to get there.
You're making the videos, so.
That's right.
That's
We can do it.
great, John.
So
And John, may I ask then, is this what you do, is make videos for a living?
No, I'm a 40-year doctor, but we've had a recording studio and a television thing for a long time.
Okay, so you're still practicing and doing this.
Oh, no, I only play with medicine. 95% of my work is medical politics. And the reason we want to do the videos is because the whole world has gone TikTok. So if we want to teach them advanced medicine or how to hit a baseball, it's a 10-second to 30-second film.
Interesting,
I,
interesting.
I had this crazy idea that we're going to take our hormone information and make it into a comic book, and that this is the result that we
That's right.
getting out of it.
One of our board members suggested we do serious medicine in a comic book form. And while we were in the process of doing that, the artificial intelligence really turned on. So what it would have taken to do a comic strip, now we can do a full-length movie in 1% of the time. Oh my
Wow.
goodness. And about
Wow.
1% of the cost. The stuff that I do now, it costs 1% of what it cost 10 years ago. So it's another
That's-
world. It's another world.
That's very exciting, John.
It
That
is.
super exciting. I really want to continue communicating with you.
Well,
I have so many ideas going through my head now already.
Well, the whole idea with this group is we are definitely a bunch of good guys, and we're trying not to eliminate anything or anybody if it can be of service to mankind.
Yeah.
So, because my question when you were talking about what you are doing, and then Bill does the hormones, general medicine, but I was wondering, in California, what is the most complete integrative clinic you've seen? We haven't discussed acupuncture, herbal, homeopathic, and right now homeopathics under attack. So what do you know?
Yeah.
But that's
Well-
what we're trying. If we could put all of these things together and be truly integrative, wouldn't it be wonderful?
Well, that's been my goal for 28 years. I firmly believe, see, my part of my graduate training in assessment was done in a clinic at a university where we staffed all these different people from different disciplines to determine how to provide service for an individual. This is Northern Arizona, so we had some Native American population. Sometimes they would have, injuries from being run over by trains. I mean, it was just everything. But what I saw 6 or 7 people do was so much different than what any individual or even small 1 or 2 people can do. I know that my colleague, David Foster, is also extremely interested in this. And he is, I don't want to toot his horn because I work with him, but he is an exceptional psychiatrist. The saying around town is people go to the first psychiatrist and that psychiatrist has trouble helping him. So they go to a second one. When he has trouble helping him, he says, all right, now you got to go see Foster. Okay, he's very devoted. He has been for 40 years. He's very down to earth, but he's extremely well-versed in what he does.
Bill,
And
you're going
so-
to bring him on, right?
I'm gonna,
Yeah.
So John,
Yeah,
you'll get me his contact. We'll bring him on.
Yeah, what do you want him to talk about?
Well,
Whatever.
we usually leave it up to the speaker,
Okay.
unless
mean,
Dr. Burgess has a bug up his bonnet about
Yes,
something.
no, man.
He can talk about like developmental trauma. He can talk about neurolinguistic programming, it's therapy. He can integrate a lot of different things.
Mhm.
I think that what would be interesting, and I'll talk to him, is how a lot of what I talked about, but in more detail, how he implements his assessment to look at supplements,
Mhm.
what kind of therapies he does with what kind of medication needs and brain stuff. Yeah, I'll talk with him.
You
I
mentioned.
would,
Yeah, you mentioned early on that you matched medications to different wave patterns.
yeah, different abnormal patterns.
Right.
He does. That's his thing. I mean, he's got a mental database of that. You know, it wasn't too long ago, there was a group that published, Emran and Sufri, published a report about being able to determine a medication based on this program they put together, but they didn't share their data. So it kind of got pushed aside. He has data in his head, you know, that we need to get down into some cohesive form of communication. You know, we're a small clinic, so we spend most of our time surviving like everybody else. But he'll look at a cue and go, oh, well, this person needs Remeron. I mean, it just boom. And then he has reduced initial negative effects of medication probably by 75%, the trial and error for psychotropics. And I
that's,
think
we like to learn how to do that.
yeah, I think that you would. I can talk to him about that and put some examples together of that. We've got years of these cues, and he's been reading them and studying under some of the people as I have. And so, you know, like John, like you said, Dr. Burgess, we really need to put our heads together and, you know, create an exponential change in these kind of things. Because I think people should be able, like you said, nowadays, people could come online, they could go get their tests, right? Their evaluations, whether it's a Q or the blood or the PT, whatever it is, and then come to a place where there are people from 10 different disciplines that put together some sort of information sharing that I think could change the way that people are helped.
Well, I think your ship has arrived, because that's exactly what we do. And we have quite a crew here and everybody's doing their best. And you sound like you want to do exactly what we're trying to do.
That's great. Where are you located?
I'm in West Virginia, 2 hours from Washington, DC.
Oh, okay.
I'm, yeah.
West
So
Virginia.
I'm from the former heroin capital of the United States. It's an interesting place. So, you know, my specialty is pain for 20 years, but we also have a major military base here and that type of thing going on. So, like I say, DC suburbs, we're actually part of incorporated Washington, DC. We're 60 to 70 miles away, but we have been incorporated into Washington, DC. So we're a major player in that whole DC scene.
Is it a circumferential, you know, does everybody within 60 miles incorporated now?
No, they got a special hand that reaches all the way out here via Senator Robert C. Byrd and our military, but it's just an old advanced military thing. But we have a lot of things going on here. We have the largest chemical production facility, I believe, on the earth. There are 2 major drug chemical household product production centers on the planet. And one is Procter & Gamble, which is right here in our town too, our small town. But it's a 1,000-acre factory with the most advanced robotic systems available on the planet. They can make anything and everything you want right here. And we also have the largest tactical military airplanes in the world. A bunch of stuff like that going on. Anyway, it's a fun place to be.
Do you have a website for all this?
I do. If I have your email, I'll get in touch with you.
Yeah, because
I can
we're
get it.
in the
I can get it.
process of,
Yeah.
I'm in the process of redoing my website.
Yeah, you only had one page.
Yeah, you pull it that. That's just, I just keep that as a place marker.
Yeah,
The gentleman
only
who's
had-
supposed to do my website sort of left, and I haven't been able to figure out how I want to, Dr. Foster and myself, to integrate a website. And that's one of the things I need to work on this upcoming, you know, starting my New Year's resolution.
We're totally happy to help with that. Hey, Bill, can you send him the flick I sent to you?
Send you what?
I sent you a video. Did you get that?
I don't know.
Okay. Hey,
Where,
we'll
you
be
know,
in
now-
touch. We'll be in touch, but what you want to do, anything visual, I can do that. So I would love to
okay.
speak with you about this, because with the artificial intelligence, we can do things with images we just could not do before. And the kind of things you're doing fall right in line with that.
Well, and that would be wonderful. And with your skills, we could attract people with brain images and things that they've never seen before to make it as enticing as it ought to be. Brain science is enticing, and yet it's not being represented as such.
Well, basically, just if we didn't talk about anything else, and we just mentioned the couple of veterans I've seen improved recently, it was just absolutely amazing. It's shocking. It's important. And without that, we would have been dealing with more suicides, more problems, more dementia for sure. But it's like they snapped out of it just looking at a computer, they said, but they're better. So I hope we can talk about all of this.
Yeah, definitely. Definitely.
He needs to see Joel. Joel is our Marine, and he's also part of our patient advocacy.
Oh, okay. There he
And,
is.
and he's been playing partner with Bill and myself forever. So that's another connection we have with the VA. And they're the ones that seem to be pushing some of this.
Well,
And I'm
it's
working on
about
some of that.
time.
I'm working on some of that government grant type environment and government contracts. I've got to get my Sam's number, my Dunn's number, and I could start approaching them about those contracts that are out there.
So
Oh,
here's your video, John, right?
Let's do it. I want to work with Joel and John and you, Bill, and we'll make it happen. Yeah. Good enough. We'll do it.
This is after the fact, John, but
Everybody,
yeah,
everything went quiet. Oh, shoot. Look what's on the screen. Isn't that cool? This is your movie.
Can everybody hear it?
there's no sound.
You don't need to hear it. It's just me talking, but you can see the
Okay.
image, the way the images, we can incorporate things.
Yeah.
So what I did, I took the title of your intro tonight, and I put your words with these images. So here you see what we're doing.
Yeah.
These are original images. We own them, we control them. So we can do some classy stuff now. It's just amazing. And kind of cool.
you're getting better at this, John.
Oh man, it's tricky, but it's so much fun. And like I said, I thought my brain would become dumber, but by using these tools, my clarity of mind has increased. Totally unexpected. So anyway, I think we have something to
Okay.
talk about, and I'd be happy to help you with this if we wanted to do this type of thing.
Right.
Great.
Somebody said you spelled psychiatry wrong.
I did. I think I spelled a few of them wrong, and most people who watch my raw films think they're disgusting and other stuff like that. Because
Well, I know-
the AI programs tend to knock out naked women. So if you want a classical view of an electron, there will be a naked woman holding it.
Okay.
So you have to be careful. Repulsive, that's a word. The works can be repulsive if you're not careful. But I'm
Okay.
careful.
Okay. I had it. Is Dr. Dan Freeland, are you still on? There was a.
Yes.
Okay. So, John, is there anything else? We had a request for asked me and I about, well, I'll let you talk, Dan. He's going to ask the group.
Yeah, I've never asked any questions, but I had a question about supranuclear palsy. One of my friends just got the diagnosis, and I've had one friend in the past, many, many years ago, 20 years ago, die of that. Is there any alternative approaches to that type of injury?
It's nothing. I've never dealt with it.
Well, I didn't think I wasn't honestly a question. I just found out today for my friend, this wasn't actually for the neurofeedback. If it would work, I'd love to. I'd buy the $2,500 machine like that for my friend and my son, actually, who's autistic. I think it's great. Thank you for whoever gave that the mind situation, quiet mind. Does anybody else have any suggestions? IV glutathione, anything like that?
What was the name of it?
Supranuclear palsy.
Well, I'm not familiar with it. What does it affect?
It is such a rare condition. The friend that I had before got it from Agent Orange, they think. This girl has not ever been in the military. She's just a teacher. So I don't think she's been exposed to anything like that. But I don't know, maybe other pesticides or something like that may have done that. But she's very healthy. She does yoga. She eats healthy. I just wanted to, I guess there's honestly nothing specific for supranuclear palsy. I'll probably just have to look it up myself and try and approach, from a more super health kind of approach, maybe.
If they came in here, we would again balance their hormones. We would see how that would work out. We would do micronutrient testing. We would try to balance the microbiome. We would look for. I'm looking more and more at the toxic mold. We had Dr. Campbell on. We're actually finding some of that. We never looked for it before.
Okay.
So that's kind of the approach that I would take. I mean, again, I don't have anything specific. I don't know if it's a neurological issue. Someone Brad.
Thank you for the Ayurveda. That sounds good.
Yeah, Boswellia, which is a homeopathic remedy. That's sort of.
I'm sorry. Repeat that, please.
Boswellia. This is Dr. Stoker has Boswellia.
Oh, okay, got it. I'll certainly look that up after we get off here. Okay.
So that was just a little bonus. Personally, I've never seen it.
Excellent.
So I might have read about it somewhere.
It's something that I primum non nocere. It's probably not going to do any harm. So
right, exactly.
It'd be an excellent thing to do anyway. So
okay.
Well, thank you so much. I appreciate the
more than welcome. Anybody who's new, if you liked what you saw, please leave me your email address so we can add you to our database to let you know what our events are. Next week we have Dr. John Neustadt. He's an ND, and he's written a book on fracture proof your bones. We're going to be talking about osteoporosis, among other things. And again, with his background, it's mostly physiotherapy, plant-based supplements, and lifestyle changes. So we'll be talking about that. Dr. Finnick, anything else? Any parting shots? Any summary? We always like a summary. Tell us what you already told us. Okay, and
well, I thank you for the opportunity.
You're more than welcome.
And I think in summary, I would just say that there's a lot of people trying to do good work out there. And I think that the more we get together, the better.
Mhm.
That's my summary.
Okay. You understand that, when the group, is really interested in your topic and they like the way you presented it all, we're going to bother you again a couple of months down the road to present again. If you did a bad job, we wouldn't call you again. So,
Oh, okay.
you know how
So
that is.
Are you suggesting already that you will, or you haven't
Yes, no, I'm
decided?
suggesting I will. If I wasn't, I wouldn't have brought it up in the first place.
All right.
Okay. Anybody
Yeah.
else? Any questions, comments? Anybody going to A4M this weekend? I am not. But they're okay. Well, Claudia, you're going to have to report for us. So A4M, in case you don't know, John, is like the biggest anti-aging conference every year. It's in Las Vegas every year this weekend. But usually I used to be a speaker there all the time, but they didn't want me this time, and then some other things ran into some issues. So I think I got a thing today though. They're having it online like this, so I might do that. Okay, so anybody that's going for A4M, please take notes. Try not to get suckered into spending $10,000 on a program in where the vendors are, which is easy to do. Stay away from the skincare people. They're the roper inners there. We'll be back again next week. Going to the anti-aging conferences never gets old. It's so true. Same time, same station. We've been here for over 2 years now. At 5 o'clock Pacific, 8 o'clock Eastern. And we get the best of the best. I mean, we get, speakers that are charge $5,000, $10,000, $20,000 for an hour at some of these conferences, and we get them for free. So,
Where do I send my bill?
you can send it to me, and I'll put it with all the others.
Yeah.
So, again, thank you so much for being with us. If you don't mind, we'll put you on our email list.
Please do.
So, whenever you have nothing to do at 5 o'clock on Tuesdays, we'll be here. Okay.
How do I get information to you? I'm new.
Give me your type in the chat, type in your email address and name, and you will be added forthwith. So
Great. I'm in geriatrics in Florida.
mhm. Okay. You are near Daniel Kaplan?
Yeah, DO.
Me too.
Great.
So Dr. Burgess will explain all about the DOs. If you just send me, okay, so this is my email address here, drbill9@gmail. Okay, and then you can write back to me. You got that there?
Okay.
Okay,
Just go under chat.
go in chat.
All right. Right. Thanks
Got
so
it?
much.
You got it? Okay. Or if you want to put yours in, if you don't want to put it in for everybody to see, just put my,
Oh, sure.
go to me, and we'll make sure. Thanks, Marie. Hooray for geriatrics.
Speaking of geriatrics in Florida, how far are you from Lake City?
A good 2 hours.
Okay.
We're in Naples on the West Coast.
There's a piece of property I've been watching for about 5 years. It was sold, came back up, sold, came back up. 23 acres in Lake City. It's beautiful. It has maybe rooms and housing for 50 people. So it's just a beautiful, piece of property. But for a gathering, for an integrative thing where you put people together, as you were mentioning earlier, that could be a place. But anyway, it's one of those that might.
We're gonna go down to Dr. Finnick's place down at Lake Tahoe there. So right.
Do that too.
We can do that too.
Right.
Okay, Dr. Kaplan, if you want to just email me, or if you want to give me your email address, we'll make sure you're part of the
Typing
group.
it in now for anyone who.
You can just put it. You can just send it to me if you want. You don't have to send it to everyone. How'd you find us, by the way?
Through Joe here in Naples.
Oh, right. Okay, right. So are you part of his group, the diabetes group?
No, we just actually met in a serendipitous way.
Oh, okay.
So I write, amongst other things, children's books.
Oh, great. Okay. All right, everybody. So I haven't gotten any. Are you typing in your?
Yeah.
Okay. Type it in for us. So it's for me, or I can get it from Joe if, oh, there we go. Okay.
Hey, I need money. Do you need a illustrator designer for your children's books?
Well, I have a good one, but there's a lot of books coming, so yes.
Let's
All
talk
right.
just for fun.
Great.
Okay. You might scare the kids away, John.
No, you can see, I sent you two tonight because you were talking about affecting a child's path if you get them early in the path.
Mhm.
So I already sent Bill 2 images tonight of children on a path, you know, so you can do some really beautiful stuff with this. Check it out.
Okay. All right.
Thanks.
I will make sure you get it, Dr. Finnick. If
And Dr. Kaplan too. I got Dr. Kaplan.
yeah, we'll get Dr. Kaplan. Maybe I'll talk to you, John, about if you like it, we can put it on the website, and then you know, pretty much anybody can see it. So, okay. Okay, everybody. Have a great night. And those of you going to A4M, I expect a full report. This is probably the first live one I haven't been to in about 15 years, but it is what it is. So next week again, Dr. John Neustadt, fracture proof your bones. So you'll need to know that, John. Right. Okay. Thank you, everybody. We will over and out, and we'll see you again next week.
Roger that.
Bye-bye.
Thank you.